Hi guys, once again Ijaz Hidayat is with you with a new talk and with new session. Today we are going to talk and going to discuss the very highly demanding topic, which is the LVAD, left ventricle assist device, mechanical circulatory support, and I get so many request from my friends and my colleagues. They want to know the information regarding the post management of LVAD patients. So let's start with the LVAD left ventricle assist devices patients. So we will try to understand the routine management of left ventricle assist devices. So first we'll talk about what is the indication of the left ventricle assist devices. So number one, it is bridge to transplant. The patient must meet the criteria to be listed for a heart transplant. Number two, the VAD is the taken out at the time of transplant. The once the LVAD implanted, then when the heart transplanted, you can remove the LVAD devices because the patient already get a new heart. Number two, it can be a destination therapy. The patient does not qualify for the heart transplant but meets the criteria for the destination therapy, so we can go for the LVAD implantations. And the patient's life is the rest of the patient's life will be on the with the support of the LVAD. Bridge to, if we talk about the bridge to recovery, so VAD, there is a few LVADs for a few days or weeks provided a temporary support. Patient with the postpartum like the cardiomyopathy, so we can give the bridge to recovery with the help of interprofessionals teams which are approaching with the help of cardiac surgeon, cardiologist, cardiac anesthesiologist, perfusionist, intensive care nurses, psychologists, assist device coordinator, as well as a physiotherapist and intensive care, as I already mentioned, the staff. So this is not a one-man show. This is the group of teams, the multidisciplinary team who's going to take care of the patients having the LVAD implantation. So if you talk about the LVAD management, so first you will get the preload, then afterload, pump speed, and anticoagulations. So if we talk about the preload, in a preload, of course, we are just managing the patient's blood pressure, central venous pressures, peripheral vascular resistance pressure, PVR mean, and the right heart function, valvular function, and the rhythm. So this is from the preload side. And for the afterload, of course, we monitoring the SVR of the patient. So the target, the mean arterial pressure is in between 65 to 85 millimeter per mercury. The pump speed, it's adjust the RPM, the revolution per minute, the blood in and blood out. For anticoagulant, the target of the anticoagulant during the LVAD implantation is we have to keep eye on to maintain the INR of the patients in between 2 to 3. So this is the actual LVAD patients management which we go through throughout the life till the patients having LVAD implantations and till the patient survival with the LVAD. The overview of the VAD is VAD is a mechanical, as I mentioned, is a mechanical circulatory support which restore the blood flow, improve the survival. It's improve the functional status and improve the quality of the life. The patient is on the floor or in an ICU, so there is three things we need to be discussed here. Number one is the patient's blood pressures. So patient blood pressure taken with the manually cuff. The automatic blood pressure reading is are considering as unreliable. If we talk about the pulse, the palpable pulse is a variable and is a clinical insignificant in the patients like LVAD patients. Pulse oximeter can be unreliable, so look physically to the patients by hypoxic or the oxygenations frequencies, the changing of the oxygenations. So you can't rely on the pulse oximeter actually. What will be happen if the patient is in ICU or in a ward then you hear the alarm from the device. So for example, if there is a two type of heart LVAD is available, like hardware and HeartMate. So these two different companies have working on the heart LVADs. So we will talk about the hardware. So if you get a high alarm, but you get alarms on the pocket controller, the flashing red alarms. You know, there is a three type of alarms: high priority alarm, low priority alarm, silence alarm. So if there's a red color alarm, it means a high priority alarm. It's a critical alarm. So flashing red high critical alarms means VAD is stopped, critically battery controller has failed. So these can be the reasons. So what should you will going to do if this you get the red high critical alarm you are seeing on the patient's pocket controller? So first, check your patient and treat as indicated. Connect the drive line, replace the batteries, or change the controller under the supervision of the expert LVAD coordinator. If the same alarm is happening on the HeartMate 2 or HeartMate 3 devices, the red alarm, so there will be a red alarm is there. So what we're going to do is, it's mean if we will talk about the red high priority or critical priority red alarms, there will be a red heart warning light on the system controller, as I mentioned. Steady audio tone. Pump flow is less than can be the pump flow can be the less than 2.5 liter per minute, inadequate to meet the patient's condition. Pump has stopped. It can be percutaneous lead drive line is disconnected, can be pump is not working properly. So these are the reasons in case of the high critical alarms in a red color. So what you can do to manage this type of patient: check your patients, make sure the system controller is connected properly to the percutaneous leads, like a drive line is properly fixed with the pocket controller. Treat any source of the low flow or shock, bleeding, maybe the hypovolemia or tamponade heart. So these can be the reason, and you can just treat the situation and manage your patient's pocket controllers alarms. Supply bag for extra batteries and backup controller close at hand. So this bag will going to help to keep the batteries and keep the drive line to be clear from any kinking and from any bending. The pump parameters. When we talk about the LVAD parameters, the first parameter is which you have to focus on, that is your pump flow. So the amount of blood flowing through the VAD displayed as a liter per minute. It was not actually, it is a calculated value based on the speed and fluctuation on the normal. Now what is speed? The speed, how fast the VAD is moving, rotating revolution per minute. The fixed speed set by the VAD team. So the on the machine, on the system, the fixed speed is set by the VAD coordinator and with the team of the cardiac surgeon. And then HeartMate may fluctuate from 150 to 200 RPM. So hardware should remain fixed. So the hardware is fixed. For example, this is fixed on the 4000. So it can fluctuate 4200, and it can be 3800. So it can fluctuate, but the speed is fixed like 4000. So the power is the energy required to given the speed display in the watt. It can fluctuation as a normal. So power will show how much there is a resistance. If the power increase, it means there is some resistance in your inflow or outflow. So there is a combination of the flow, speed and power. When you are assessing your pump flow, so as I told you before, the average adult cardiac output is rest and like a 5 liter per minute. The body depend on the body size, blood volume, effect of pump flow potentials. What are the flow parameter as estimated? The flow will mainly fluctuate with the changes in effect, body positioning and body volume. It can be hypervolemic or it can be hypovolemic. Other physiological condition can be affect flow like a right heart function, rhythm disturbance, hypertension, valvular function, pulmonary hypertension and thrombosis. These can affect your pump flow. So you have to go through with the T and checks. So check the your patients. The most common event happening for the patient, like for LVAD patients, and the suctioning event is called a PI event, PI suction event. So a suction event occurs when the pressure inside the ventricle drop too low, or causing the internal canal to adhere to the left ventricle septum. This typical results from is because of the hypovolemia or high pump speed, poor internal cannula positioning, or it can be for due to the tampon heart. So in a suction event, event isn't life threatening. It cannot be a life threatening, but it can lead to be a ventricular rhythm arrhythmias if you're not going to treat the PA event or suctioning event, such as ventricular tachycardia can happen. So what is the management of PA suction event? You can manage the suction event by fluid to restore the ventricular pressure, surgery to restore the proper cannula positions. So these are the management of suction event. Sometime the most like at long term the patients on an LVAD, there is a RAM study which will going to happen with the support of the echo. So in a RAM study, at each speed the patient mean pressure as well as echo parameter should be obtained. LVAD septum will in RAM study we check the septal position, frequency, duration of the aortic valve opening, and we see the quantitative or qualitative AR, MR and TR. AR mean aortic regurg, MR mean mitral regurg, and TR mean tricuspid regurg. When making the speed adjustment or speed optimizing on the T, incremental changes of 200 to 400 RPM are used. So by adjusting 200 to 400 RPM, you can adjust the speed of the pump by seeing all these parameters like this, the position of the septal. So going to see so it should the opening of aortic valves. So this the RAM study is the one of the important tool to adjust the patient's pump speed and pump flow. Patient who has on a long-term follow-up, so the thing I already mentioned with you, we are always focused as a post LVAD coordinators or LVAD taking care of the patient team members. So we always, whenever the patient came for to visit to the hospital, we always check the patient's pump speed. Pump speed means revolution per minute. We see the patient's power. Power means the watts, how the energy is taking, the motor is taking the energy. Pulsatility index is the pulse index, and of course estimated pump flow on the pocket controller. So additional review of any recent alarm, and in the meantime we also see that any alarm is there in the log events. So we go through with that so that we can get a proper information related to the patient's details. So we'll talk about the pulse index, PI. So pulse index is the measurement of assistance, the LVAD providing the LV and providing the range from 1 to 10. So the normal pulse index of the patient is on the monitor, you are going to monitor is 1 to 10. If this is in between the range of 1 to 10, it means the patient is the normal. So if it go beyond, then you have to think about the reasons why the pulse index increase. So the pulse index is calculated based on the pulse flow pulses during the systolic, which are sensed by the LVAD and average over duration of the 15 seconds. So low PI indicate the pump is contributing more to systemic flow and translate to less pulsatility. The higher PI mean the higher pulse index indicate the less pump contribution to this patient, and pulse index value should be remain relatively constant, and the decrease and a decrease should lead clinician to consider a decrease in circulating of blood volume. Significant increase in the PI should promote further evaluation for the possible fluid retentions, hyperdynamic states as sepsis, significant maybe aortic valvular insufficiency, and in a rare instances cardiac recovery. So pulse index is used to quantify the flow variations, the flow average over 10 to 15 seconds and divided by the average flow according to the formula maximum flow minus minimum flow, average flow around the 10. So higher LV contribution to the pump flow or less LVAD support relative to the residual LV contractility and will result in elevated in the pulse index. So lower LV contractility or higher LVAD speed, more LVAD supports will reduce the neurometer and the formula, and pulse index will be in the lower sided. The time when patient is going home, so LVAD patient will receive one system controller, two set of the batteries as a primary operator set and backup battery as a backup support. Power base unit and control monitor is required at the initial implantation and subsequently encountered to review the setting alarm, but is not required component for to discharge time to going to handle over to the patient. So normally we are giving one extra pocket controller and two extra batteries to the patient, so and even the battery charger. So patient having the battery chargers, two battery backup and power, one pocket controller. In case of any emergency or patient get unconscious, so what is going to happen? The airway resourcing, breathing oxygen, in verifying the pump is running or not, verifying pump is on, likely confirming the pulse on the VAD patients, rule out the VAD power on driveline disconnected or reconnect. In case of it is disconnected, so reconnect back, verify the VAD is running or not, listen from like this, you will get the sound on the pump over the apex. If an alarm is present, so make silent it. If the pump is on, then of course life support measures with the CPR only after looking for the viability. Continuous airway support, resource the breathing, assess the rhythm, ICD firing, amiodarone, VTAC, VFAB. So for in case of VTAC or VFAB, you can give the amiodarone. Even in case of ICD firing, you have the force amiodarone with the supporting. In case of cardioversion, as per the ACLS protocol, go through with that. Assess the Doppler blood pressure. You can see the patient blood pressure. Establish the patient IV. Use core drugs as indicated. But in case the pump is not working, VAD is stopped, so VAD equipment failure is very unlikely. But in case this happened, you can go through to change the pocket controller or VAD controller, pocket controller of the patients with the backup controller. Hope today's sessions gave you a brief detail about the LVAD management and LVAD overview. Have a nice and good day. Take care. Bye bye.